even starting back in middle and high school, because a lot of the people around me had things that they were struggling with, and they didn't have an adult that was their advocate the way that they always needed it. I saw that it was hard to communicate about symptoms to a lot of people. And so in middle and high school, I was like, okay, I'm going to be a counselor. That's what I'm going to do. I'm going to do clinical psychology. That's my plan. That's my goal. And then I got to college, and the adjustment from living at home to living in a state 12 hours away from where my family was hard. So I was like, oh, if I want to be a counselor, I'll go practice what I preach, right? I'll go see a counselor and actually see what that's like. I don't think this is a good fit. And me being able to say that as a client, being like saying, I don't think this is a good fit, changed my whole approach to being a clinician myself, because now I get to say that to clients. I get to tell them during the informed consent process that, hey, there are going to be times where I might try to practice something with you, or I might review a list of coping skills. And I might say, okay, we're going to try mindfulness for a little bit, or we're going to try meditation. And if at any given point I suggest something that does not work for you, you know yourself better than I do. You are your best advocate here. And I want to be a supporter of you in living your life the way that you need to, not how I tell you. So if I say something that hits you wrong, if I suggest something that is not an option for whatever reason, maybe you've tried it in the past and you know it doesn't work for you, I want to be the person who listens and doesn't keep trying to do the same thing over and over again. I want to adapt to where my clients are at, not necessarily where I want them to be.
Hello, everyone. This is Dr. Moss. I am here with an amazing guest that I'm very excited because we have not chatted in over 10 years. We went to high school together and we were very good friends. So I'm so happy to hear her story and her journey since we've last chatted. So this is Delaney Romine, who's a graduate student pursuing her master's in clinical mental health counseling at Capella University. With a passion for mental health advocacy beginning in early life, Delaney officially began her career in mental health at the start of 2020 and has been working in community-based mental health with adults and children ever since. As she pursues her license, Delaney aims to use an integrated theoretical approach to create a culturally appropriate and trauma-informed space for her clients to work toward their professional wellness goals. Thank you for coming, Delaney.
Hi, I'm so excited.
Oh my goodness.
This is so fun.
I'm so excited to hear about your journey, especially since it sounds like it was relatively recent, but I want to hear a little bit about your journey into the health professions.
Yeah, absolutely. So my journey to being a counselor started when I was really young. Back in middle school and high school, I was the group mom. So and I remember at the time being really interested in mental health, like even starting back in middle and high school, because a lot of the people around me had things that they were struggling with, and they didn't have an adult that was their advocate the way that they always needed it. I saw that it was hard to communicate about symptoms to a lot of people. And so in middle and high school, I was like, okay, I'm going to be a counselor. That's what I'm going to do. I'm going to do clinical psychology. That's my plan. That's my goal. And then I got to college, and the adjustment from living at home to living in a state 12 hours away from where my family was hard. So I was like, oh, if I want to be a counselor, I'll go practice what I preach, right? I'll go see a counselor and actually see what that's, because at that point, my PCP had already told me that would be a good idea for me. So I was like, okay, cool. It's been medically recommended. And then my counselor wasn't good. And it wasn't her fault. In retrospect, I'm looking at a lot of, as I move forward in my career, I've been looking at a lot of those interactions from that first counseling experience and being like, oh, I see what you were trying to do here. This is why it didn't work for me, which informs my approach, which is great. But at the time, I was so devastated because I didn't want, as somebody who was sitting on the other side of the client clinician experience, I did not want my client to feel the way that I had when I shared something with my counselor. And a couple weeks later, because it had been going well, she was like, oh, so you don't have this issue. You were just homesick. And I went, no, but you know what? If you think so, because whatever I'm talking to you about seems subclinical in terms of what I've disclosed, then maybe this isn't for me because I don't want to invalidate someone who's coming in sharing very real symptoms and very real struggles that are presenting subclinically and therefore not eligible for treatment on that symptom. And so I ran out of that office and changed my major from psychology to, at the time I was doing theater because I wanted to do drama therapy. It was really but, and then slowly as I got more into theater, I was like, this isn't a good fit either. This isn't just what I want to do because I was really enthusiastic about patient care. I went to health science as my major because I was thinking about maybe doing PA, maybe doing epidemiology, like a lot of different things because there were so many things in that big umbrella of health professions that I was like, this is so cool. There's so many cool things. And I got my degree in that, graduated, started working in the field in home health, and found that in home health, particularly, there were a bunch of people that were being treated as numbers. And I didn't like that. And I wanted a patient care experience that was much more personable, where I got to sit with somebody and I got to really explore issues. Went back to counseling finally and was just like, okay, career counseling, this is what we're going to figure out. And she was like, you've been talking about how you wanted to do mental health interventions through a career in health science, whether that was like PA, whether that was something like that. But you're telling me that the things that you're discussing with other professionals at this point is that you're not going to get what you want out of this career because you want time and the ability to develop relationships with people. And she goes, it doesn't sound like you want to do this. It sounds like you want to do mental health still. And so, and I was like, you know what, you might be right. And she actually recommended going into community-based mental health as a bachelor's level professional just to try it on and see if I liked it. And so I did, and I just fell in love with it. And that was around 2020, and I haven't. So
That's amazing. I love that transition, and it's so human to be able to come in and out of different degrees, different experience to figure out what do you really like? Where is your passions lie? And I encourage so many undergrads to be like, if there's not just doctor. I feel like that is such a thing in the pre-med culture is there's one profession and there's so many. Same thing.
there's so
PhD,
many.
psychologist. There's so many. And I really wanted to ask you later the difference between a counselor, social worker, and therapist, because I have no idea about that path since I didn't explore that path, even though I did a degree in psychology. I was like, okay, PhD in psychology or MD psychiatrist. Those are my ways. So I'm very interested in that path and what you how you decided on the different path for you.
That was a big part of my grad school decision-making process because there are a lot of ways that you can practice professional counseling. So you can be and the acronyms are different in every state. So I'm going to use the ones for here in Virginia. But here in Virginia, we have licensed professional counselors or LPCs. We have licensed marriage and family therapists, LMFTs. We have licensed clinical social workers, and then there's licensed substance abuse counselors, so LSAC. And when I was looking at programs, one of the things that I was evaluating, because social work is a really flexible discipline. If you get a degree in clinical social work and if you get licensed in clinical social work, you can do a lot of different things. You can still do a lot of case management. You can do a lot of like working in schools as a school social worker, working in like I mentioned earlier, back when I was working in home health, we had a social worker on staff that was our quality assurance coordinator and would make sure that we were meeting all the needs of everyone that we were servicing. And then you can also do counseling. Clinical social worker is a really flexible discipline where you can work in a lot of different capacities that aren't just counseling. And it is more informed by everyone is influenced by their theoretical approach, but social work as an ideology tends to be much more systems focused and looking at how these systems around us influence us as individuals and how social dynamics and sociology can impact the individual as they're experiencing life, which I love that about social work. I love the system, like the systems approach, but I wanted to be a little bit more specific in how I approached counseling. So I was looking between marriage and family therapist or licensed professional counselor. And marriage and family therapist, you can do the same thing. You can do individual counseling, you can do family counseling. A lot of it is more based on family systems theory and learning how to counsel within relationships and improve those relationships within that specific scope of practice. So it might be more like, hey, I'm doing premarital counseling. I'm doing marital counseling. I'm doing relationship counseling. I'm doing family counseling. And like all of these things you can do across any of these licenses, right? But the approach for marriage and family therapy is very specifically oriented toward relationship management and improvement. And then there's your LPCs, and these are usually like your general counts, like your generalized counselors. They're individual, they're group, they're marriage and family therapy as well. This is where you get a lot of your, I would say you get a lot of your stereotypes from licensed professional counseling because your Freuds back in the day really laid the groundwork for what we're doing now as counselors, which is you have your clinician in the room and you have your client no longer laying down on a couch. But one of the reasons that I selected LPC is because when I was looking at the different education programs for state requirements and state licensing, I was like, okay, which one is going to give me the most information that I can learn about and the most broad scope of practice that I can then use information to customize what I want to do when I'm in my profession and I'm working with a client. And to me, the most like when I was looking at curriculum strictly, I was like, although I know all of these are going to promote a very inclusive and very integrated curriculum, LPC felt like the best option for me to have a specific career focus with a generalized career knowledge. That, yeah.
Okay, I think I'm starting to get the idea. That is really helpful. Thank you for explaining that. And it's impressive how many varieties there are and really specialties of what you can do within each different path. I know you talked about moving away from home and going to college and feeling homesick, but then still needing to go to a counselor and support and getting support. Is there any other challenges or even triumphs that you experienced during your education that really impacted you?
A lot of things.
It's
uh,
always it's never just one.
looking back, I'm like, there were a lot. So the adjustment from being a student in high school to being in college was like an adjustment that pretty much everyone goes through, regardless of whether you move away far from home or even if you're still in the same town. And it's big, it's hard because suddenly you went from, yeah, as a teenager, developmentally, you're steering your ship a little bit more, but your parents are still on it, to college, or like your parents or your designated adult support adults are like still on your boat and you're driving and they're like making sure that you are going in the direction they believe is right for you. And then you get to college and they're off the boat. They're on their own boats now. And suddenly you're driving without like as much influence. Like it's still valuable from your like support adults, but you're driving yourself much more independently at that point. And I think that's hard for anybody, figuring out who you are when suddenly that scaffolding is no longer there. I would say that it was very valuable for me to have some distance just because I felt that I could explore a lot more of what independence meant for me, which also led to its own struggles. But I could explore a lot more what independence meant. I could also explore what family relationships meant to me when I was farther away from them because my family had always been very close. So it was interesting to figure out like how can we be close while we're physically far away. But as far as other things that influenced me in education, I think a big part of my journey getting to where I am now is figuring out largely a lot of my own mental health things. There have been relationships that have had impacts on me, for better or for worse. There have been really positive relationships. There have been ones that have been really hard to deal with. I think, especially in the health professions, imposter syndrome has always been a really unfriendly, close familiar that hangs out because we're talking about all of these things, all of these skills, all of these, and really all of these recommendations that we can make for effective treatment and evidence-based treatment. But sometimes we know from experience that's really hard, or we're looking at it and being like, hey, let's practice boundary settings. Meanwhile, you're like, don't look at my house. Let's talk about boundaries. Let's talk about communication, and being like, okay, but I do passive communication and people pleasing and like all of these.
Yeah, it's so hard. Yes. Oh,
So imposter syndrome is kind of always brutal.
yes.
And then as I've gotten older, I'm realizing that a lot of things that I used to struggle with very much when I was younger are like actually symptoms of other stuff going on. There's a suspicion that ADHD is in the mix for me, which would have been nice to know when I was a child. But now I'm figuring out how to deal with that as a grad student. And that's really interesting. But it does, I think a lot of those struggles inform a lot of how I approach care with especially neurodiverse kids. And it's been huge. So my own struggles are very informative in terms of how I practice and trying to be inclusive and appropriate with practice.
Thank you so much for sharing that. Those are so real and so common that I experience and so many other students and people experience. I was actually just this morning on TikTok, a physician and a guy who he said he graduated residency in 2012, and he was saying that he just moved to a new work environment and he was experiencing imposter syndrome. And I was like, wait,
Yep.
how are you, Mr. Successful, like already finished your career, already making all the bucks, and you're still having that emotional experience of not feeling good enough, of not being where you should be? And it's scary. I also really like that you said that you brought in the concept of neurodiversity. And that is a big thing right now that I'm really noticing and really keeping like an eye on, because it is something that a lot of the individuals that are close to me in academics and even as like close relationships and friends, they're starting to also, they're looking back at their own academic struggles and realizing that they didn't have the support system when they were younger to be diagnosed for whatever reason, whether if that was just we went to school in an area that everyone worked as hard as you can and you hid, you were the good girl, or they would just push aside maybe if you were hyperactive, then that and maybe identified as a male as a child, that was more easy to be like
Mhm.
ADHD. And but if you were identified as a female, less likely that you would identify that they would support you or start thinking of you as being neurodiverse. So you're
Right.
really not alone. There are definitely even a lot of people I've interviewed on this podcast that are in PhD and med school and grad school that are realizing that, hey, maybe my struggle is not just that it's hard. There's some other resources that I can gain that maybe would just help me a bit.
My brain works a little differently.
Yeah. And that's totally normal. But it's really good that you're starting to realize, oh, what can I do to make sure that I can still learn the material and follow your passions?
Absolutely. And it does take, like you mentioned, those learning what resources work for you.
I'm wondering, you said earlier on kind of your own experience with a counselor and being the patient has really impacted how you see that patient provider relationship. Could you talk more
Mhm.
about that and how you look at it as you hope to practice?
Yeah, absolutely. So I think one of the things that was really important for me to experience just in terms of being on the client or patient end of that relationship and of that relationship dynamic is that there are good fits, there are not so good fits, there are good therapists, there are bad therapists. It's a continuum. There is so much distinction in the providers that will meet you where you're at with what you need to be met with. And as a clinician myself, I'm looking at various things, especially going from that client side and becoming the clinician. It's I look at things that didn't work well for me in therapy, or I look at things that I really just disliked as a client. For example, at one point I had a therapist that just was not a good fit for me. And I remember my therapist before then who was a really good fit for me, but things happen and transitions occur. But I remember one of the things I've been working on with my previous therapist was like being assertive and working on boundary setting skills and really trying to be more comfortable occupying space and dictating like how things would meet my needs appropriately. And I went into this other counseling session trying to be open-minded. And the first thing she did, she was like, okay, we have to do this. And I told her, I was like, listen, I don't think we have the rapport to have established this yet. And actually was really proud of myself because I'm sitting there being like, oh, look at me. I'm advocating for myself. This is great. And I was telling her, and I was like, listen, we don't have enough therapeutic rapport established for me to feel comfortable talking about goals in this way. Can we adjust these questions so I can feel a little bit more exploration while I'm also getting to know you? And she was just like, yes. And then she would go back to asking the same questions. So she just kept resetting. And I was sitting there going, and at the end of that first conversation with that counselor, I was like, I don't think this is a good fit. And me being able to say that as a client, being like saying, I don't think this is a good fit, changed my whole approach to being a clinician myself, because now I get to say that to clients. I get to tell them during the informed consent process that, hey, there are going to be times where I might try to practice something with you, or I might review the list of coping skills. And I might say, okay, we're going to try mindfulness for a little bit, or we're going to try meditation. And if at any given point I suggest something that does not work for you, you know yourself better than I do. You are your best advocate here. And I want to be a supporter of you in living your life the way that you need to, not how I tell you. So if I say something that hits you wrong, if I suggest something that is not an option for whatever reason, maybe you've tried it in the past and you know it doesn't work for you. I want to be the person who listens and doesn't keep trying to do the same thing over and over again. I want to adapt to where my clients are at, not necessarily where I want them to be.
I love that. That is something I'm a huge proponent for all across the health profession, of being able to empower patients to be like, this is my body, this is my time, my space. And if something's not working for me, if I don't feel safe, to for the healthcare provider to provide that safe space to give them to allow them to say no, or let's do something else. I was just listening to someone who called it, oh my goodness, it was a specific type of consent where that consent can be revoked at any time. Specifically, they
Mhm.
were talking about in medicine where we're actually putting hands on patients, that even if someone did consent for you to, let's say, just listen to their heart with a stethoscope, if that patient doesn't feel comfortable with that, they have the right at any point to say, no, please don't touch me.
Please don't do that anymore.
Yeah.
Yeah.
And that's just not how medicine is structured. There is a
Mhm.
huge power dynamic, and it's really good. And I love that about therapy, of how you all work really well to be able to set the playing field to maybe even change a little bit of the power dynamic, or to be either
Absolutely.
more equal, or give the patient and the individual the power, because it's for them.
Absolutely. Yeah. That's the goal. It's for you. It's not for the therapist.
Right. And you know what, something I was thinking about, and it would be really cool to get your perspective, because therapy and counseling is so different training than medicine. I would love to hear your thoughts on the patient provider dynamic, because you said, like, talking about fit, and I know you and sharing your own experience or about you, like, how is it in counseling? How do they recommend? Is the counselor supposed to be like a blank wall, kind of the psychodynamic perspective of the patient can say anything, and the provider just agrees and listens and doesn't share kind of their own story and background? Or is it more of a kind of collaborative back and forth, or is it a kind of a mix?
That's a really great question, because it's very much informed by the individual counselor's theoretical orientation. So, yeah. So, like you mentioned, psychodynamic, there's a lot more blank slate. And some of those earlier theories, a lot more blank slate. Even the early development of person-centered care and humanistic psychology is very blank slate, but warm, unconditional positive regard, where it's like, yes, I'm not going to give you a whole bunch, but it's going to be nice. It's going to be a really nice face, and I'm just going to listen. And there are so many valuable inputs for all of these different theoretical orientations. For me personally, I tend to go for a lot of postmodern counseling approaches. So we have, and in postmodern, there's a lot of your dialectical behavioral therapy. You have acceptance and commitment based therapy, solutions focused therapy, even reality therapy, narrative therapy, like all of those things. Again, I'm very integrated in my approaches. So there's a lot of names and a lot of theories. And then one theory that resonated very strongly with me early in my grad program was existential therapy. And one of the things that existential therapy emphasizes is very much like what you were talking about with that collaborative counseling relationship, where the power dynamic is very like, obviously you still have a patient patient provider relationship or client clinician relationship, but it brings it down a little bit where the clinician can use a little bit more self disclosure, like obviously within ethical and appropriate limits, but there's a little bit more sharing, like how do you derive meaning from the world? Like how do you individually derive meaning from the world, and what does that mean for you as a person? Don't follow my path, follow yours. But it emphasizes this very like more even playing field. And for me, I really like that because I like being able to be just like myself when I'm working with clients, and I'm not a blank slate person. I can't do it.
I'm the same way, so I get it. Totally.
It's hard because I'm the person who someone will say something during like in my work now, and someone will say something and it just catches me and I just turn and I find myself so frequently being like, girl, what did you say? Like
I love that. Yes. Exactly. Yeah. It's more person to person, human.
person to person, human to human.
Yes.
And I tell a lot of my clients a lot of the time since I've started working in community-based care, which is I am not the expert in you. You are the expert in you. I am just the cheerleader who wants you to have all the good things. And I'm a cheerleader, but my pom-poms are textbooks. And that's what I tell my clients.
I love that. I'm gonna have to say that my pom poms are textbooks.
My
No,
pom-poms
I
are
love it.
textbooks.
What does that mean, community site counseling? Does that mean, yeah, what does that mean compared to, I don't know, academic counseling?
So this is where I get to be really excited because I didn't know that this was a resource for so long. And since working in this field, it's just like, oh, I know so many people benefited from having this information over my life. But so community-based mental health is typically refers to various disciplines of what we would call in-home counseling or community-based rehabilitation. When I first started back in 2020, I worked with mostly adults and some children, but what I was community-based rehabilitation and case management. So I would when I was acting as a case manager, and I would be the same for all of my clients, I would do both. But when I was acting as case manager for that session, it would be more about, hey, we're going to get you linked with different resources in your community. I'm going to make sure you know where the food banks are. I'm going to make sure you know how to schedule appointments. I'm going to make sure I am the person who's kind of you're like, here's all these things around you. Let's draw the strings to you so that you know how to access them. Whereas community-based rehabilitation, and these were the abbreviations back in Idaho, they're different everywhere because why would we have standard acronyms? But community-based rehabilitation was more about working with clients who had various diagnoses, whether that was schizophrenia, whether that was borderline personality disorder, whether that was bipolar disorder, a lot of pathologies with very strong symptoms that impact daily living in a huge way. And what we would do is go out into the community and practice skills that they needed to deal with those symptoms when they were going through the day to day. So I would schedule 2 to 3 hour appointments and we would be like, okay, we're going to go to the grocery store because I know you get anxious in grocery stores. Not only am I going to be your backup while you're in the grocery store, so if you get anxious, you have somebody there with you to walk through the process and help you feel a little bit more empowered and bolder to go out into the community. But I'm going to sit there with you. And when you start experiencing anxiety, I'm going to be like, okay, we've talked about deep breathing. Let's try that together. And, or even when it came to some folks who were struggling with communication, it was me modeling, okay, we're going to go into this store in this session. I'm going to ask the questions from the clerks, the sales associates. I'll show you how to ask those questions with appropriate guidelines for sharing and listening, appropriate social skills, assertiveness, like all of those things. And so I'm going to model those for you today. Next time, we're going to alternate. So I'll do one, you do one, I'll do one, you do one. And the time after that, I'm going to be behind you while you're doing it to see how it worked and then we would review how that felt afterwards. since I moved to Virginia, it's now intensive in-home counseling, therapeutic mentoring, mental health skill building, and all of this kind of changes depending on how old the client is. So since I moved to Virginia, I work a lot more with kids and I love working with kids. It's super fun. When I'm working with kids, I'm now working in an in-home setting most of the time. So I'll be in their house for between usually 1 and 3 hours, and I'm working with the child that I'm assigned to, and I'm also working at least once a week with their whole family. And it's working in the home to make suggestions because I get to then see for up to 10 hours a week. What does it look like when you leave your therapist's office? What does it look like when you're at home and suddenly these systems that I'm not going to see when I'm in my office, or I'm not going to see when I'm on the computer. Now I'm seeing the skills that you learned in therapy and how they're coming out at home and if they're coming out at home. So my clients a lot of the time are referred to me right now when they are at risk of out of home or out of school placement because of their symptoms. So I'm coming in and again with up to 10 hours a week being like, okay, what do we need to do so you can stay stable at home? And I get to work with most of my clients for between 3 months and 3 to 4 months, and then sometimes longer. I like the longer stints because I feel like I get to actually get in there and work through more things with some of my clients, but it's a lot of intensive skill building with everyone at that point because and learning how to, if I'm working with a family, being like, okay, I see that you guys are getting upset with your child's trigger. However, the thing that's triggering your child in this moment is the way that you asked them to do something. Because when you asked them, it didn't sound right. Or in some situations, being like, hey, you don't like when your child speaks this way. Have you noticed that they learned it from you?
Yes, the
Maybe.
interactions for sure of in the house of reciprocity, definitely.
And like kids learn from modeling. So they're
Yes,
going to be
that was the
doing
word.
what their parents or guardians are doing.
Oh my goodness. That is such a cool variety. I was a case manager for children with disabilities, and I'm seeing a lot of the things that you did just with this additional training and being able, like a kind of a combo between like the behavioral therapist that I interacted with, plus the responsibilities I had as a case manager, plus a little bit of it's really cool how integrated and how you can be able to pull from different things like your background and your different trainings to be able to mold the needs for the individual clients. Like you said, patient.
Patient centered, always patient centered.
Yes. As we, I know we have to close up, but I know we mentioned something at the beginning before I clicked record and you got me really interested in it because of all the years I knew you and we were such good friends. I had no idea you were a Latina. And I
Yes.
think that is powerful in the sense of how did we both, I went to your house. How did I not click? How did I feel like from like looking back at my little high school self, I'm so sad I didn't know that because I would have had someone that maybe would connect with me and understand that challenge of looking white on the outside, but being still this root. And I would love to hear quickly, I know it's not a quick conversation, but whether if it's advice from that experience or anything, because I've talked with other individuals who are also navigating being Latinx or being marginalized, having some sort of marginalized identity while also pursuing higher education.
Right.
That
You're
wasn't
right.
really
It's
a
not a
question.
short.
I'm realizing
Well,
that
no, I
wasn't
know where
really
you're
a
going.
question, but like the concept.
More an open
Yes,
discussion.
open. Take it however you want it. So whatever you like
And
to.
I'm like, you're right. It's not a like short.
It doesn't.
But yeah, so going back, like talking about high school, because I mentioned a little bit that like in high school, I spoke about it, but where we lived, it was very homogenous. It was largely like the demographic was predominantly white. And like when I think back about our high school environment, the amount of microaggressions that happened on a daily basis that weren't always very micro, but they were just uninformed because we lived in a bubble. Like I look back and I'm like, okay, this is why I didn't talk about it. because I didn't want to bring up this part of my heritage and this part of my ethnicity that was so valuable to me and critical for me, only to then know just with certainty that I was going to be called spicy. I just was like, I don't, especially in the friend group, because it would have been like with love and affection, but I just didn't want that, did not want that. I had a few friends in high school who knew, and even those conversations reflecting back on them, I'm like, oh, not great. It felt fine at the time because that was the relationship we had. But in retrospect, I'm like, oh, that was pretty ugly to deal with regularly. And I think I started talking about it more in college because it became more of a conversation. It became because on my college applications, I got to very proudly say, mark the box that was like Hispanic or Latino. And I was like, yes, I get to talk about this to people. And then through college, again, I was in a very homogenous area with a lot of primarily white folks around me. And I would talk about it. And there were still a lot of microaggressions because not only am I Latina, I also really enjoy a lot of things that are very central to culture. So one of the reasons I've loved salsa dancing and learning Latin dance for so long is because it felt like there was a very unique feeling where I would go there and I'm like, oh, I feel at home. This feels right. The music feels right. Everything feels like something I didn't get to celebrate at some point. So it was just so important for me to learn Latin dance and at the time try to practice my Spanish skills, which have since diminished greatly. But like I think there were a lot of times socially where I just didn't bring it up much because didn't always want to deal with because I have a lot of white privilege because of how I look. I gave myself the pass to just not have to deal with what people would say if they knew, but that also had the flip side of now I hear what happens in white spaces when they think no one can hear. And as I got older, I got more comfortable with being like, hey, like not always necessarily disclosing like, hey, this is my ethnicity, this is my heritage, but more the, hey, like I'm sitting in a place of privilege because of how I look, because of my skin color. I get to use that privilege now to say, hey, that's not an appropriate thing to say about people. And you don't need to know like my ethnicity to back up why that's not an appropriate thing to say to people. But I get to call it out a little bit more because I get to be in those spaces. I would say also going into like my career, there have been times I now live in an area that's much more demographically diverse. So I get to work with people who are different than me every single day. And I would say that now my experience being white and Latino is really central to like my interactions with others because I've had children that I work with that are white passing, but that are white passing and black. And so we're then talking about, okay, how do you interact with your culture and your ethnicity while also recognizing that being white passing is going to impact your ability to engage with that culture and like how people will talk to you. And that's systemically going to have impacts. And like when talking to other staff members, like there have been times where people don't know, or even I've told people and they forget because and when we're like working together with a client, we've had conversations where it's like, hey, like I can teach, especially with my kiddos that I work with that tend to be more like passing or very light or benefiting from colorism in some way. We have these conversations where like I will have coworkers be like, I can teach them about this cultural experience and you can teach them about being white. And I'm like, or I can teach them about what it means to be light skinned and have an ethnicity that you want to engage with, but there are barriers for it because there are barriers for it. And here's why. And they're not barriers that impact you in the same way that they impact the people on the other side who are going to be discriminated against much more quickly than you will. So you're going to have privileges, and this is the impact of you having privilege on engaging with your culture. This is going to be the impact of you engaging with your culture on your privilege. And those conversations with other clinicians are always really interesting to me to be like, yeah, remember, we can't always assume what's going on behind face value until we ask. So
literally
yeah.
face value. I love that is really helpful. And that's what you just encapsulated of talking about your own life experience growing up as a privileged face, but internal marginalized identity and multiple marginalized identities, how that has impacted how you interact with clients, how you interact with colleagues, and this huge benefit it is to be able to provide power and advocate for others is literally, I think, sums up the reason why one of the main reasons why I created this podcast was to demonstrate the power and the like how important it is to have this diversity in the health professions, in medicine, because that's what the United States looks like and is. And so we should equally have that in our health professions and our helping professions to take care of others.
Absolutely.
Well, Delaney, as we finish up, are there any pearls of wisdom that you would like to share? You already shared so many. Are there any particular that you would like to pass on to the audience, particularly any other individuals that are in the education realm, also navigating health, like education with disabilities or with like yours and with invisible disabilities and health conditions?
For,
Sorry.
okay.
Did
Sorry.
it? Yeah, no,
My
I'll say it
Wi-Fi
again.
just
No
dropped.
worries, no worries. Are there any
Okay.
pearls of wisdom that you would like to pass on to any individuals that are navigating education with invisible identities or even invisible disabilities and health conditions?
So hard. Like, I think one thing that actually, this is something that I'm borrowing from a classmate I had at residency not too long ago. Steps backwards are still progress. Missteps are still progress. And resilience is hard. Resilience is hard and it's developed through time and it's developed through making mistakes and being able to keep it moving and keep adapting and keep changing. Any step, no matter what direction, is progress. And that would be my big thing.
Those are beautiful. And I think I'm going to also steal them from you and your colleague because I resonate with that a lot. And I think a lot of
Mhm.
other individuals will too, because life isn't linear, even if we wish it was, that it isn't. And I like what you said of any steps in whichever direction, there's still progress. So thank you, Delaney, so much for your words, your story, your journey. And I'm going to finish off by just giving a summary of everything you said, a little bit going your journey all the way from high school in Colorado, always being a passionate about mental health, being the mom in the friends group, which I do remember that. Now that you quote words to that, I'm like, you're totally right. Delaney was the core, and I never connected why. And that was exactly it. Whenever there was an emotional challenge, you're the first person that we texted every time. And I'm so happy to hear that you've taken that skill, that just who you are, and now have broadened that to flourish for other individuals. So I'm so thankful to hear that. So you learned how to be there for other people, but then going to college and realizing that college and that transition is hard for anyone, but you really recognized how it is beneficial to receive counseling and support and ask for help. And you did that. And even if it wasn't the perfect relationship, the perfect connection, you didn't let that deter you for too long. You might have switched a major, but that didn't change the core of you did not give up asking for help. You did not give up following your dreams and finding at least where your passions and where your skill set is. And as you navigated college, dealing with relationships and imposter syndrome, you still were able to found the licensed counseling that sounds like you're almost done. You said
Almost one more
residency?
year.
One more
One more
year.
year.
Okay. And then you talked a lot about kind of the differences between counselor, social work, and what it looks like to be really community based, be there for patients in their home, maybe spending time in the real world with them to try to support them, not just in a bubble in a clinical office, but out in the real world where people exist. And that is so important. And then lastly, you talked about just the challenges of growing up in the Boulder bubble that we always heard about, but it's hard to really understand until you leave that bubble.
Leave and go back, and you're like, oh,
Yes. Oh my goodness. Yes. Be like, oh, now I understand why it's called a bubble. And you were able to move out and really be able to find yourself and find where you were able to express your Latin heritage through salsa dancing, through sharing, not always disclosing, but still sharing your experience to advocate for other patients. And even when you might be in a homogenous environment, still be able to advocate for others and use that privilege, that white passing privilege for a benefit of others. And then lastly, you mentioned you provided pearls of wisdom on resilience is through making mistakes, and only through keep going and not giving up can you really have progress. It doesn't matter what direction, right? It doesn't matter which direction of your steps. I love that. Delaney, again, thank you so much. If people would like to connect with you, how can we best do that?
I tend to keep a lot of my socials and stuff really private just because
That's fine.
clients.
That's fine.
And I'm also just never on socials.
That's totally fine. Can maybe they email me and then I can pass them your email?
Yeah, absolutely. I think I do also give the option. So on socials for people who are like who have professional questions or even like
Yes.
who want to exchange information, like
Yes.
my Facebook, Delaney Taylor Romine, or my Instagram also, which I think is Lula Fox. But Delaney Taylor Romine on socials, and you can find me.
I love it. Thank you. Do you use LinkedIn at all?
I do. I do.
Would LinkedIn help for
LinkedIn would help.
Sometimes it's a good one for, like you said, in the professional and other individuals that are maybe interested in maybe that career path that you talked about and might be and navigating all the different paths. So LinkedIn is good.
Yeah, okay. LinkedIn is good. I'm just Delaney Romine on LinkedIn. I gotta fix that at some point, but
right. Congratulations on your marriage and your name.
Yeah, it's exciting.
Awesome. Thank you, Delaney, once again. And thank you to everyone who listened in. If you haven't already, subscribe on wherever you're listening, whether that's YouTube, on podcasts, Amazon, Spotify, all those podcast area. And then if you haven't already, check out my website, medpsychmoss.com, where you can find blog posts where I talk about imposter syndrome, failure, living as a Latina, psychiatry, mental health, all those things, all those fun things. So I hope if you're in the health professions, some of those things are helpful. And then please, I like to end by saying you are not alone in your struggle. I hope that these episodes share that you can still have struggles in your life, whether that's academics or personal. That's just human. And I hope you can realize that you can keep following your dreams and not let those challenges prevent you from giving up. So thank you, everyone. And I hope to see you all next time. Oh, I forgot to say social media at MedPsychMoss. I decided to keep it, even though I put the MD at the end, but I kept it MedPsychMoss because medicine, psychology, or psychiatry, and then my last name, Moss. So I hope you all see you online. I hope to see you all at next episode. Take care, everyone.